All right, so we're going to start off with the signs and the symptoms of a patient with chronic obstructive pulmonary disease. Now, sometimes you might be, if you've actually kind of been exposed to this stuff, you might have heard the term blue bloater and pink puffer. These are common kind of terms that we utilize for patients with COPD. Now, that blue bloater is going to be common for someone who has chronic bronchitis. Okay, so what I'm going to do is I'm going to write down blue bloaters. And again, just remember that blue bloaters are more particularly for patients with chronic bronchitis. The other one is your pink puffers. And pink puffers are going to be those patients who have more particularly emphysema. Now realize, again, they often coexist, but one of them might be a little bit more severe than the other. Now, patients with blue bloaters, what do they mean by this? Let's get the big term out of the way. Why they mean blue bloaters, why they mean pink puffers. Well, the easy one is bloaters, they're chunky. They're a little bit big, all right? So they are commonly seen to have a obesity, okay? So they're seen to have a high BMI. The other one with the blue goes back to that hypercapnia I was talking to you guys about. Remember, chronic bronchitis, one of the big things that I told you was hypoxemia, which was low oxygen, and what else? Hypercapnia, high buildup of CO2. Because of that, over time, it can lead to cyanosis. Okay, cyanosis, which is going to be that bluish discoloration. That's why they're referred to as blue bloaters. We'll go over more. Again, I'm just giving you why they refer to this and how we can try to separate these so where it's easier to remember. Pink puffers. Now, pink puffers, these are generally because they exhale through pursed lips. Okay, so they exhale through pursed lips. And the reason why they exhale through pursed lips is it helps them to prolong the expiration. Okay, so it helps them to prolong the expiration. And another thing is they're pink because, remember what I told you, these patients have hypercapnia, again, because of the airways kind of collapsing. But their hypoxemia is not as bad. Remember why I told you that? Because they can get air in. That's not always the problem. It's trying to get air out. So because of these, usually in the early stages, they can properly oxygenate. Okay? But again, it's whenever it gets to the more severe later stages that they lose that ability for them to oxygenate properly. And again, it can lead to that severe hypoxemia, which can then progress to cor pulmonale. Remember, pulmonary hypertension, right ventricular hypertrophy, right ventricular failure, and then again, that can lead to the signs that we can see from that. Okay, what are some other things that help us to determine the difference between someone who's a blue bloater or a pink puffer? Again, with these ones, chronic bronchitis, one of the hallmark signs, I can't stress it enough. Again, remember what I told you. For emphysema, structural changes. For chronic bronchitis, mucus production, plugging. So these guys, one of the hallmark signs is a chronic, productive cough. This is the big one that I want you guys to remember. And again, that's that productive cough that's rich in a lot of sputum. Why? Remember, they have so much mucus buildup, they got to get rid of it somehow. And one of the big ways that they do that is by hacking that up. Okay? Another thing with chronic bronchitis is, again, we already went over the hypoxemia, we went over that stuff. But another thing that we can see with these patients is that they have wheezing. Okay, so that's another sign. So whenever we're doing auscultation, we're listening to the chest, we hear wheezing, but particularly on expiration. And you can remember why. Again, as you're exhaling, the airways are actually so mucus plugged so that it's having a hard time for the air getting out. And that's that sound that we hear as wheezing. Another thing is you might even hear crackles. Crackles are rails. Okay, but these are inspiratory. So sometimes you might hear what's called inspiratory crackles. Now, it's not too hard to understand this. Here's what you got to remember. With this inspiratory crackles, remember that airway was so plugged up, okay, with mucus. that whenever we exhale, again, the actual airway gets a little bit smaller and obstructs the air getting out, causing air trapping. But whenever we inhale, remember what can happen is that actual airway is so plugged up, sometimes what can happen is whenever you're really trying to breathe, it can pop those airways open. Okay, so whenever you actually are trying to take air in, it pops those airways open and produces that crackling sound that we can hear upon inspiration. They also call it rales. Another thing that we can actually see with both of these patients is usually they also have kind of an increased anterior-posterior diameter, and they can also have, so they might have an increased AP diameter. And because they have so much air in their lungs, when we try to percuss the actual chest, the thorax, it can produce hyperresonance, okay, to percussion. All right, so hyperresonance upon percussion. So these are things that we want to take into consideration when we're talking about chronic bronchitis. But again, I can't stress enough this one, chronic productive cough, because here's why. We can make a clinical diagnosis of actually chronic bronchitis. We'll talk about what it is, but usually if they've been coughing consistently with a productive cough for at least 3 months in a year for 2 consecutive years, that's one of the criteria that we can go about by saying this person probably has chronic bronchitis, okay? So those are things that we go with for this one. Now, pink puffers, we already talked about that they breathe out, they have prolonged expiration, they do it through pursed lips. The reason why they do that is it helps to be able to keep a positive pressure in the airways and to keep them from collapsing. Remember that Bernoulli principle. If we breathe slowly, what it's going to do is it's going to keep some air in those actual respiratory airways to keep them kind of slightly opened, okay? And it's also going to kind of create some resistance. Again, think about that Bernoulli principle. But because they're kind of breathing through pursed lips and prolonged expiration, that utilizes a lot of accessory muscles for breathing. So because of that, sometimes these patients will have weight loss. So that can be a common thing that we see. Another one, oh, and I can't forget another one here for blue bloaters, and I'm going to write this down right here, is they have what's called dyspnea on exertion. So in other words, they get short of breath based upon moving, upon walking, upon getting up. Anything that requires a lot of effort is going to cause a severe shortness of breath. Okay, so that's another really, really big one for blue bloaters. But again, weight loss is a common one. And again, go back to these other things. It can cause wheezing. Okay, it can cause wheezing on expiration. Again, because those airways are getting so narrow and they're collapsing. Generally don't hear inspiratory crackles for these patients, but again, they do have that increased AP diameter, and it's more common for these patients to have that increased AP diameter because of that significant air trapping. And they're also going to have hyperresonance to percussion. Okay? Now, with these patients, it's not always clear cut. But again, the ones that I really want you to remember here is that for blue bloaters, it's a chronic productive cough and dyspnea on exertion. For pink puffers, I want you to remember that they breathe through pursed lips to prolong their expiration. Because of that prolonged expiration, it helps to keep the airways, try to keep it open, but it can cause weight loss. They can oxygenate usually in the early stages, but over chronic periods of time, it can lead to chronic hypoxemia and can lead to chronic hypercapnia, which can lead to right ventricular heart failure. But again, that's more common with blue bloaters. Again, a significant increase in AP diameter is also common, but again, they both can have that, and they both can have hyperresonance to percussion, and they both can have wheezing on expiration. Chronic bronchitis, you can have those inspiratory crackles because of the mucus buildup. Whenever you inhale, it can actually try to pop the airway open. So those are some of the common things that we're going to see in patients who have the signs and symptoms of the chronic obstructive pulmonary disorder, blue bloaters, chronic bronchitis, pink puffers, emphysema. Next thing we're going to do is we're going to go into the diagnostics here. Okay, the hallmark thing here, well actually let me do the first one. The first one that I really want you to remember is you can do these kind of sometimes based upon clinical diagnosis. Okay, in other words, you take into consideration their history. So you look to see if they're a smoker. You look to see if they work in situations where they're exposed to a lot of dust, pollutants, or silica. You try to take and see if they have a family history of COPD. You look to see if they have some underlying liver disorder, because again, remember the alpha-1 antitrypsin. Sometimes when situations, if you don't make that alpha-1 antitrypsin, it can cause destruction of the liver. So they might have liver destruction. So you can check their LFTs. But again, you can go just based upon history and physical examination, particularly if someone has chronic bronchitis. If someone has chronic bronchitis, remember I told you, one of the big things that can kind of tip you to think about this one is if they have 3 months per year times 2 years of productive cough. This is one of the big things that kind of leads us to believe, oh man, this definitely could be chronic bronchitis. Emphysema, obviously we could try to look for the, some of the signs there. One of the big things is you could do, it's not always the best, it's not really what we go with, but you could do a chest x-ray. And what a chest x-ray was showing, I'll put that down here, is it can show hyperinflation of the lungs so that you can see that they're really, really big. You can also see that because the lungs are so big, the diaphragm's really flat, and they have lots of spots of what's called lucency, dark spots, on the chest x-ray too. Okay, but that's one of the big ones that we can go with. We can kind of just go based off history and physical examination. But the gold standard here, that would be the best possible thing here, would be to do pulmonary function tests. So pulmonary function tests. And again, we talked about this in physiology, and we went over the graphs, and we went over a lot of the stuff with the force spirometry. We went over the inspiratory reserve volume and expiratory reserve volume, total lung capacity. So we have videos on our physiology playlist in respiratory if you guys want to watch more of that. We're going to kind of go right into it though and talk about what kind of things we see that are abnormal. Okay, so what we look at is we have them do spirometry, we have them take like an apparatus, we have them take as much air as they can in and breathe out as much air as they possibly can. And what we're looking at with this is we're looking to see 2 particular numbers first. So the first thing that we look for is we looked at their FEV1, and this is just basically their forced expiratory volume in 1 second, and we look at their FVC, their forced vital capacity. In patients who have chronic obstructive pulmonary disorders, both of these are low, but this one is even more significantly low. So the FEV1 is more significantly low or markedly lower in someone with COPD, and the FVC is also low as well. Now, the next thing we can do is we can do the ratio. So if you imagine here, you can take the FEV1 and you can divide it by the FVC. And if it is less than 75%, that is a positive sign that usually this is an obstructive pulmonary disorder. So this is usually a positive sign of some type of COPD. And again, that could be COPD or it could be any obstructive lung disease. It could be asthma, it could be bronchiectasis, it could be cystic fibrosis. So those are some of the things that we would look at. But here's what we would go to. We would take their actual pulmonary function test, their FEV1 and their FVC. We would give them a bronchodilator. And a bronchodilator is just something like SABA, so it's basically albuterol, and that's basically a beta-2 adrenergic agonist. In other words, it binds onto a beta-2 receptor and causes smooth muscle relaxation to open up the airway. It dilates the airway. That's going to help them to get more air in. However, with COPD, it's irreversible, unfortunately. So they'll have a small increase in their FEV1 after you retake it, but it's not going to be big enough. So what we do is we do the bronchodilator. We'll take these tests, we'll do the bronchodilator, and we'll remeasure afterwards. And usually after the bronchodilator, the FEV1 is still less than 12%. There's a less than 12% increase. And that is usually a sign of COPD. Okay, if it's greater than 12%, then that might be asthma. But what we do is, again, we take their pulmonary function test, we take their FEV1, we take their FVC. They're both low. FEV1, more low. We do the ratio. Usually if it's less than 75%, then we say this is an obstructive pulmonary disease. The next thing we do is we try to monitor. So we do a bronchodilator, like a SABA, albuterol. Then after we've done that, we have them do the pulmonary function test again. They're still going to be low. But what we look for is we look specifically at that FEV1. How much did it change? If the change was a 12% increase or above, that's more likely asthma. If it's less than a 12% increase, that's most likely an irreversible situation, and it's probably COPD. Okay? So that's how we go about with this test. And again, this is the gold standard for this one. So this is the one that you definitely want to try to do. Okay. Other things that we could do is we could look at their pulse ox. So their pulse oximetry is another one. Again, what did I tell you with these situations here? With patients who have chronic obstructive pulmonary disease, they can develop hypoxemia. So what you might find with these patients is that they might have a low O2 saturation. And that's what you're going to have to look at. You're going to want to look to see how significantly low is it. So what we look for is we look to see if their O2 saturation is less than 88%. That usually means that we got to start supplemental oxygen. Okay, it's not a good sign. Okay, we might have to put them on a nasal cannula. Or if their O2 sats is less than 90%, but they have predisposed factors, maybe they have right side heart failure, or just in general some heart failure, and they have an elevated hematocrit, maybe they have polycythemia, then again, we're probably going to want to start them on supplemental oxygen. So we usually have two thresholds. One is if it's less than 88%, we can get them started on supplemental oxygen. Or if it's less than 90%, we can increase the threshold if they have heart failure or an elevated hematocrit. But we'll also base it on another thing. So the other thing that we do is we do an arterial blood gas. And an arterial blood gas, what it does is it gives us a couple different things. It gives us bicarbonate. It gives us the partial pressure of CO2. It gives us the partial pressure of oxygen. And it can give us the pH. Now you got to think about this. If a patient has COPD, what did we say was some of the big things that we would find? Remember, they're not able to get CO2 out. So there would be, most likely, elevated CO2. What is that called? Hypercapnia. What I want you to remember is, in patients who have elevated CO2, remember that equation back from physiology. CO2 plus water yields carbonic acid. Carbonic acid can dissociate into protons and bicarbonate. So if you have a lot of CO2, you have a right shift. And that builds up a lot of protons. What can protons do to the actual blood plasma? Make it acidic. So you might notice a decrease in the pH. Remember what I told you, that it also can actually decrease the oxygen and cause hypoxemia. Usually because when someone is in his respiratory acidosis, they might have a compensatory change in bicarbonate, but we're not going to talk about this one. Okay, that's more specifically for metabolic acidosis or alkalosis. But these are some of the things that might lead us to believe that they might have respiratory acidosis. Okay? And another thing, I remember I told you that we'll talk about it later, but when we start people on supplemental oxygen, we do it based on their O2 sats. But if we do an ABG, we can also base it on their oxygen. Usually we set it at less than 55. So anything less than 55, we say, okay, let's start them on supplemental oxygen. And again, 55 millimeters of mercury. Or if it's less than 60 because they have right side heart failure and elevated hematocrit, again, we can start them on supplemental oxygen. But that's what we would go to for the arterial blood gas. So the next test that we could do here, and it's really good just to kind of rule out cardiac disorders, is we can do an EKG. And really all we're doing the EKG for is to rule out, maybe a myocardial infarction or congestive heart failure. And sometimes what you kind of have, especially in someone who has a COPD exacerbation, it can happen. It can produce this thing called a multifocal atrial tachycardia. They also call it MATs. All it is it causes these irregular QRS complexes, but they have 3 distinctly different P waves, one after another. And the reason why is that they have 2 thoughts. One is because in situations where there's hypoxemia, the cells of the actual atria can try to actually set their own rhythm. And so there can be multiple areas of the atria that are firing at the same time. Another one is if someone is actually taking blood pressure medications. Sometimes in blood pressure medications that can also cause it as well. But again, with EKG, what we're trying to look at is we're trying to look for MIs to rule out anything like that, and we're also looking to see congestive heart failure. Especially, one thing we can actually do is we want to see if there's any right ventricular heart strain. Sometimes you can see if there is right ventricular heart strain, right ventricular strain. You can look at the EKG and sometimes you might see inverted T waves. So sometimes that can come about as well. So again, the reason why you would do an EKG is to really rule out any cardiac issue. But again, if somebody has this COPD exacerbation, sometimes because of the hypoxemia, it can cause this multifocal atrial tachycardia with 3 distinctly different P waves with irregular QRS complexes. And if you want to see if a patient is maybe having signs of right ventricular heart strain, they have some inverted T waves. But again, looking for right side heart failure, EKG is not going to be enough for that. You might have to do a BMP, an echo, and a Swan-Ganz catheter. Okay? The last one that we're going to talk about, generally it's not that great, but you can do it. You can do chest x-rays. You can also do high-resolution CTs. Those are a little bit better. Chest x-rays aren't as great, but high-resolution CTs can be also utilized. And what they'll show is, so we'll put HRCT, is it can show air trapping. It'll generally show air trapping. So hyperinflation of the lungs, right? It might even show a flat diaphragm if you get a chest x-ray. So again, on the chest x-ray, you'll see some air trapping. You might see a flat diaphragm. Again, you can still see that increased anterior-posterior diameter as well. You might have some lucency in like the anterior chest wall as well. For emphysema, you might see bulla. Remember that. You can see bulla. And remember which one. That distal acinar emphysema was one of the ones that you can see the bulla commonly in because it can rupture. And a bulla is just basically an air pocket, okay? Just an air pocket that as easily can rupture because of its, over time it can be distended. In emphysema, you can also have decreased vascular markings, whereas with chronic bronchitis, you might have increased vascular markings as well because of the, again, think about it, that pulmonary hypertension. Maybe in the later stages of emphysema, you might have increased vascular markings, but generally it doesn't have that much. Okay? So those are things that we would go off of the chest x-ray or the high-resolution CT scan. So again, to go through it really quickly, clinical diagnosis, especially with chronic bronchitis, 3 months of productive cough for a year, for 2 consecutive years. Do your PFTs, can't stress enough, this is the gold standard. So if you don't remember any of the other ones, at least remember this one. Okay, and again, what we look for is a low FEV1 and a low FVC, but more the FEV. Less than 75% tells us obstructive. Bronchodilator will show less than a 12% increase. Pulse ox, you're looking for low O2 sats. Generally, the cutoff is less than 88% to start them on supplemental oxygen. Arterial blood gas or an ABG to look to see if they have any respiratory acidosis. An EKG to rule out any cardiac situation like an MI, heart failure, particularly to see if there's any right ventricular heart strain, seeing that inverted T waves. And if they're in an exacerbation, sometimes they have multifocal atrial tachycardia because of the hypoxemia. And again, you can do a chest x-ray or a high-res CT. It can generally show you these common signs, which is air trapping, a flat diaphragm, an increased AP diameter. Again, emphysema, usually decreased vascular markings. In the later stage, it might show increased vascular markings, but chronic bronchitis will be more of the specific one to show you those increased vascular markings because of the toll that it takes on the pulmonary hypertension and the heart. So one more additional thing you could do, but it's not necessary, is a CBC. Only reason I'm mentioning this, I want you to think back to that physiology concept again. If you have hypoxia, what would that actually do to your kidneys? It would stimulate the kidneys to make erythropoietin. Erythropoietin is a hormone that stimulates your red bone marrow to make more red blood cells, erythropoiesis. So you might suspect them to have an elevated red blood cell count, polycythemia, an elevated hematocrit. But again, that's not diagnostically specific, okay? So again, that's going to be the big thing for being able to diagnose COPD and specifically trying to see if it's chronic bronchitis or emphysema. So one other thing that I wanted to mention with the pulmonary function tests is, again, remember that the lungs of a COPD patient is going to be super compliant. And the reason why is they're going to have, again, that elastic tissue damage. So there's going to be a lot of air trapping, as we've said many times. So because of that, the volume of air that's in the lungs in general is going to increase. So our total lung capacity of the patient is going to increase. And even if we exhale, remember the problem is exhaling air. They're always going to have a lot of air trapped in the lungs afterwards. What's that called? The volume of air that remains in the lungs after forceful expiration. That's called a residual volume. So there's going to be an increase in the residual volume. One of the things that they actually do to test it is they can actually do what's called diffusion lung capacity with carbon monoxide. They can give a little bit of carbon monoxide and they look to see how much of it diffuses across the respiratory membrane. In these patients, they have a decreased DLCO. Okay, so they have a decrease in their diffusion of carbon monoxide. So their actual lung diffusion of carbon monoxide is going to decrease. So they give a little bit of carbon monoxide, but because of the decrease in the surface area or because of the obstruction, again, it's going to cause a decrease in the diffusion of the actual carbon monoxide across that membrane. So these are things that we can see upon the pulmonary function tests. All right, engineers, so in this video, we talked about the symptoms, we talked about the diagnosis of COPD. I hope it made sense. I hope you guys enjoyed it. If you guys did, please hit that like button, comment down in the comment section. Please subscribe. If you guys want to go in our description box, we got links to our Facebook, our Instagram, our Patreon, or even our GoFundMe page. If you guys want to go there, keep in contact with us. Also, if you guys can donate, we would truly appreciate it. As always, Ninja Nerds, until next time.